Good morning. Today I'm going to talk to you about osteochondritis dissecans in the youth knee, specifically secondary school setting. So, what is osteochondritis dissecans? Osteochondritis dissecans is a pathological condition that results in the destruction of subchondral bone with secondary damage to the overlying cartilage. So if you look here, you see this lesion here with damage to the overlying cartilage. Down here you can see in this x-ray where the arrow indicates there is a small subchondral lesion in the patella, which is what we're specifically looking at. Osteochondritis dissecans can be separated into two categories: juvenile OCD, and adult OCD. Generally, juvenile cases will have a better prognosis, spontaneous healing, which is usually non-operative treatment. So for our case study, I looked at a 17-year-old male. He's a varsity football player. He's one of our better athletes. He's a senior. So his mechanism of injury is running the ball, planted his foot, had a low tackle from the outside. We did a standard eval, looked at negative Lockman's, negative varus valgus, negative McMurray's, negative posterior jaw. However, we did find a positive Houston's plica test, which is similar to McMurray's, but with your hand at a little bit different placement to palpate where that plica would be. He was tender palpation over the medial knee, kind of diffuse, and also over the medial patella border. He could ambulate, however, it was kind of wonky, so he had a little bit of an antalgic gait. I suspected a medial plica that had somehow gotten irritated. So we removed him from the game. We did have the team physician take a look at him, sent him for imaging via our Saturday morning injury clinic, and he saw one of our primary care orthopedics who recommended that he get an MRI. The MRI did come back with a medial plica, which is what we suspected, but we also saw a kind of small to moderate but stable OCD of his patella. We decided to pull him, rest him for about 7 days, do the standard rice treatment. After about 7 days, he was pain-free. We started physical therapy, did a lot of single leg stuff. So we did single leg squat, single leg Romanian deadlift, put him on a spin bike and cranked the resistance up, and did single leg spinning, obviously bilateral on both sides, but single leg. After about 2 weeks, he was still pain-free and started to look real functional, so we sent him back to the formal setting and let a physical therapist do some functional testing with him. He did really, really great, so we returned to play. We decided to return to play, send him back to a surgeon just to make sure that was okay. Surgeon cleared him to play. So this was about a 3 to 4 week process, which is a little bit unusual. Usually we see moderate to severe OCDs conservatively take 4 to 6 weeks. Luckily, this was not as bad, and we returned him pretty quickly. Here's what we found in the research. Cahill found that about 50% of juvenile OCD lesions will heal with non-operative conservative treatment. That being said, Kochner et al. Suggested a 3-phase non-operative treatment, where the first stage was immobilization until they're pain-free. Second stage is rehab, emphasizing range of motion and low-impact quad and hamstring strengthening. And then after that, there's the initiation of the return to play protocol, running, jumping, cutting, with a gradual return to sport-specific activities. This looked really, really similar to what I did with this kid. It was just a much shorter. Each of the phases was much shorter than what Kochner found in his research, but mostly because he was looking at more moderate or severe OCDs. Lastly, I wanted to give you guys an idea of what the operative treatment was. Unitani found that in his study of microfracturing, that all patients, he had 71 patients, made a complete recovery in 6 months, and all but one were pain-free. So if we look at microfracturing, also called transarticular drilling, basically what they do is where there's the subchondral lesion, they take and they microdrill into the cortex of the bone. And the thought is that they will bring in all the good stuff. So the stem cells and all the healing things and the chondrocytes, and it helps regenerate this articular cartilage. So, luckily, my athlete didn't have to have microfracturing. That's what we thought we were going towards, but he made a pretty good recovery. And now, that being said, we will send him back to the surgeon now that we're in postseason to see where he is at and if he's has appropriate healing. Here are my references. If you guys have any questions, please post them on Canvas, and I'll answer them when I can. And have a great holiday.